Excellent. Thank you very much, Sean. Thank you for the invite and for the introduction. I'm a consultant orthopedic surgeon based at St. George's. My subspecialty is hip and knee arthroplasty. 50% of my work based around revision arthroplasty and 50% of my work based around a primary joint replacement. St. George's Hospital, one of the 4 major trauma centres in London. The way the trauma network works in England, whenever there is a major accident or patient with polytrauma, the ambulance crew by default will take that patient to one of the 4 major trauma centres. And if the patient was admitted or presented themselves to one of the local hospitals with multiple injuries, then there is a protocol in place where the patient being transferred from the emergency department of that local hospital to the emergency department of one of the 4 major trauma centres. As you can see from the map, St. George's Hospital covers mainly the southwest London area. In terms of the elective arthroplasty work, we have the complex arthroplasty unit based at St. George's Hospital. But more importantly, we have a very successful partnership with another 5 local hospitals where we, together with these 4 hospitals, 5 hospitals, we share the Southwest London Elective Orthopedic Centre. We perform on average around 5,000 elective orthopedic operations per year, nearly 3,000 hip and knee joint replacement. We perform most of our primary joint replacement in the elective orthopedic center and most of the straightforward revision arthroplasty in the elective orthopedic center. But still, on that center is not about delivering volume. We have a very good patient capture and outcome database where all the patients being followed up for 2 years after surgery, recording the functional outcome, patient satisfaction, and complication from any surgery, and all these data being validated. We have very strict post-operative X-ray images, quality control, all the post-operative X-ray images being looked at and measurement being taken for any X-rays. And we have very strong research unit on that center. In terms of the revision arthroplasty, we perform a weekly regional arthroplasty MDT meeting with all the regional arthroplasty surgeons. We discuss all the post-operative images for all revision arthroplasty. Also, we discuss all the coming revision surgery coming over the coming 2 weeks. And if there's any complex surgical or medical case that one of the surgeons want to discuss, we can review that case on that meeting. This meeting will give us more the quality reassurance that we are delivering good quality of care to our patient. It's part of our clinical governance, and it's also improve the care to our patients. At the end of the meeting, the patient who being discussed will receive a letter from the chairman of that meeting to say your medical case was discussed today in the arthroplasty MDT meeting. These are the findings, these are the recommendations, and your surgeon will discuss further plan with you, which is building the confidence to the patient that every possible things has been explored to provide them with the best outcome. With arthroplasty surgery, as you know, there are certain cohort of patients which are more complex than others. We still perform primary joint replacement at St. George's Hospital with the complex arthroplasty unit. These patients with renal dialysis or patient with hematological problem, because we have a big hematology center, so we operate on sickle cell disease patient, on thalassemia patient, hemophilia patients, as well as lymphedema patient, because we have a big lymphedema center there, and a lot of lymphedema patients being referred to us where there are certain protocols to look after these patients in terms of the admission and perioperative care. The complex revision work, we still do it at the base hospital at St. George's Hospital. And this is because all the infection work done there, because we have a strong link and strong infrastructure enable us to provide this work. We have strong link with the microbiologists and the infection specialist disease, where we can review the patient on MDT meeting with them and establish the correct treatment for each patient. We have also input from the plastic surgeon when complex revision for infection patient may require a local flap. We perform combined surgery with them. All patients, as you will imagine, will be high-risk patients, so they're referred to high-risk anesthetic clinic, and then any optimization required to be done will be done perioperatively for these patients. We also have strong support from specialist nurse practitioner, physiotherapists, and all these platforms enable us to provide the care for this type of complex surgical patients. When we go back to the coronavirus, as you remember, the first case in the UK was confirmed toward the end of January, and gradually the cases start to increase, but the official lockdown came until late March. When the lockdown was introduced, it's completely changed the healthcare system that is delivered in the UK, and affected our NHS in 4 main areas. Affected the elective surgery and the outpatient clinics, affected how the medical staff being distributed inside the hospitals, affected the way we're admitting our patient to the hospital, and we start adapting new practices for trauma that we normally don't do in normal circumstances. So the outpatient clinic, we're all familiar, the setting of the outpatient clinic in the UK usually booked well in advance. Usually our clinic books with a minimum 6 weeks notice. Mean when the lockdown has come into action, a lot of these patients, they already have their appointment booked 2-3 months in advance, so it will too late to cancel the clinics. All our patients received a text message prior to their clinic to ask them do not attend the clinic, and they will receive a telephone consultation by one member of the surgical team. We start in contact with the patient by phone. As you can imagine, the follow-up patients were much easier to deal with because these patients, usually we have seen them in the clinic, we initiated investigation for them, and in the follow-up, usually we are discussing the result and further management. All patients had an operation before, and we just follow up them to ensure that they're making the good progress as planned. The more challenging consultation over the telephone, it's usually the new patient. Although many of patients have an images performed by the general practitioners in the community or by the physiotherapy referring centers, but nevertheless, we still needed the face-to-face consultation. So we start using this clinic as triaging service to initiate further management in the future for the new patients. Elective surgery was stopped, this including the cancer surgery. As a result, we lost the theatre session. We not only lost the allocated time for the extra operating session, but the theatre staff from anesthetists, from ODP, theatre scrub team, they all been deployed to support the team at the critical care unit, because the problem in the pandemic was providing enough critical care beds, and there were huge needs for anesthetists or anyone trained in that field to support in the critical care beds. The hospital asked all members of the staff to fill out a questionnaire, and the idea to do risk stratification for all members of staff. So identify those who are immune compromised, those have serious medical problems, high BMI, any risk factors, and identify who are at a high risk of getting infection and having a high risk of morbidity if they develop the COVID-19 infection. And the idea was to pull all the members of staff who are at a high risk from delivering frontline care to the patient, and ask them to do another duties where they are less likely to be coming across a patient with confirmed COVID infections. We also been asked to provide support to other medical specialties. We deployed a lot of our junior doctors because our elective services have been stopped. So a lot of our orthopedic registrars and SHOs want to support the medical specialties. We as orthopedic consultants, we were helping the team in the critical care beds and provide as much time for as much support to the medical team, providing time so they can have more manpower in that area where the need is most. But you can imagine with time, people start to get sick. Not necessarily themselves, but at least one family member of the family start to get sick, then people start to have to isolate, and then we start to have more absence and shortage of staff with time. We normally, in our practice, we do a daily trauma morning meeting for, as most of the orthopedic departments in the UK. That has changed quickly to a virtual meeting. The idea to avoid 20 or 30 people sitting in a small seminar room to discuss cases and provide more social distances between the patients, the member of the staff. So some people start logging from the clinic or from the operating theatre or wherever, any place they are in the hospital, they log in, and we use different software then, but finally we use the Microsoft Teams, which it does the job very well for us, and we were able to have a virtual meeting on daily basis. This is something we took over from the pandemic, and we still continue to use it. That doesn't necessarily all the people have to be on the same room for the trauma meeting. On the initial phase, the hospital admission has been divided into two main pathways, red and green. The red for any patient with respiratory symptoms, even if they're not confirmed to be COVID. And once you go to the red zone, that means you're going to go to the red zone of the emergency department. If the patient needs X-ray, they go to the red zone of the X-ray department, and so on. They go to the red ward. And then be isolated all the way through the red pathway of the hospital. On the other hand, patients with no respiratory symptoms, they go completely green pathway. But it was very soon become very clear to all of us, this is a very crude way of differentiating the patient between the red and green, because many times patient may have tonsillitis and is not right to pass this patient through red zone of emergency department where a lot of COVID patients there. So later on, that's been evolved into red and amber and green. Red is confirmed COVID cases. Amber, we are not sure, waiting testing, and green being tested and negative. And later on, this pathway has evolved again and changed 2-3 times. And it just shows the adaptation to what the service needs. So you adapt with time, we adapt based on the demand you have in your hospital and change the pathway to what you think is the safest on that particular moment. Operating theatre were completely a different experience. Many surgeons who operating during that time, we start operating wearing the FFP3 mask. And while many of us, we find it is okay for this short operation for 20 minutes, half an hour, 40 minutes, but when you do 2 or 3 hours of revision surgery, that was really uncomfortable to wear that mask for such a long period of time. So that was one of the things we are not used to it, and we find it really took time to adapt to it. And there was a lot of concern initially about the aerosol generating procedure. From what related to orthopedic is using the drill or using the saw. In the initial phase, we were not sure how safe using this procedure. Does this increase the risk, especially if you operate on COVID confirmed cases? Does this increase the risk to the staff who are inside the operating room? The other aspect of the operating theatre, we have changed the setup, how the operating room function. As you know, normally we have an anesthetic room in most hospitals. The patient move to first they move to holding bay, and then with time come closer to the operation, they move inside an anesthetic room where the anesthesia delivered while the scrub nurses are preparing the set in the actual operating room, and then the patient moved from the anesthetic room to go inside the operating room. We had completely a new setting developed, and we had training all different members of the surgical team to that new setting. So we do team brief case by case rather than per list. And once we're happy, the patient will be brought in straight from the ward to go inside the operating room. So the patient will not spend time in the waiting area or in the holding bay to minimize contact with any member of staff or with other patients. Once the patient inside the operating room, we have the anesthetic team enter the room and they deliver the anesthesia. Everyone else will be outside the room because that's the most risky part during the intubation of the patient if the patient going for general anesthetics. Once the patient being intubated and we have closed circuit, the rest of the team will enter inside the room. The scrub nurses will start opening the sets and preparing the surgical set, while the surgical team will position the patient with disposable PPE. And then we start scrubbing. Once you're inside the room and a member of staff inside that room, they're not allowed to leave the room. If they have to leave the room, that means they are not coming back to the room again because they're leaving from different job where they have to dispose all their disposable PPE they're wearing, and they have to wash their hand, and there's a certain protocol to be followed. And as you can imagine, with such a setting, we created a lot of drawbacks. First, we need double the number of members of staff because you have anesthetist and ODP inside the operating room, but if they needed any extra kits or any drugs, they have to ask another ODP who is standing outside the operating room to bring that drug to them. Same apply with the implants, with kits. And you can imagine if you're doing a trauma case and you have the screws are individually packed outside. So for each screw, you have to ask for a member of staff to ask the scrub nurse who's outside the room to bring the kits one by one. The rationale behind that was any reusable material should be disposed at the end of each COVID case, and any reusable material then should have a deep cleaning to minimize the cross-contamination. But as a result, we require double the time we need per operation, we require double the number of staff we need for each operation. And through that time, there was a lot of daily guidelines and protocols coming from the hospital locally as well as nationally. One of the national guidelines that most of us familiar with is the management of patients with urgent orthopedic condition and trauma during coronavirus. This came from the British Orthopedic Association. It was very important guidance and very important time, not also to shed a light as what's the best way and what's the consensus on the best way of managing these patients, but also to give a support to the surgeons should they started treating patients slightly different what's the normal standard of practice. And it got details into the general orthopedic trauma, and as you can see on the bottom, the other emergencies like codoquinal, like septic arthritis, prosthetic joint infection. If we look into the trauma cases, for example, they advise to more focus on day surgery, which makes sense. Patient coming in the morning, have surgery, go home on the same day, and in this way you have a minimum stay inside the hospital where you have a lot of COVID patients. But also big emphasis on using non-operative treatment, whether this is a plaster cast or removable splint, and we're starting to use more of the elastic cast where we can remove it at home, and recognizing even if that can lead to malunion and later on the patient may require reconstruction. That's a very strong statement and very important to support the surgeon during that time, because that's where done in very special circumstances during a pandemic where certain fracture we normally operate on them, but when it's borderline and can be managed non-operatively, we will go through this pathway. In terms of the arthroplasty work, the two emergencies we face in arthroplasty work, either infection or periprosthetic fracture. The main one will be joint infection. And what the recommendation came up with, try to utilize non-operative management as much as we can by using a suppressive antibiotics, whether intravenous suppressive antibiotics or even oral antibiotics, and delay any surgical intervention when possible, i.e. when the patient is not septic. And certainly we manage a lot of these patients during that pandemic non-operatively. Patients have urgent aspiration. Once the result available, the antibiotics change according what's the sensitivity of the antibiotic. The patient is aware there is, he will or she will require surgery at later date, while taking into account the general circumstances of the pandemic, we agreed to that will be the safest option for certain patients. The other issue came up during that time is consent. We always pay huge attention to the consent and to the shared decision with the patient, but something new started to happen that we are now consenting patients for COVID-19. We're not only consenting the patients for the actual surgery. And we have a guidance from the Royal College of Surgeons of England, which was also very useful guidance with a lot of detail. Many of these detail being targeted toward the elective surgery, but nevertheless can be applied for emergency surgery. And the four main areas we need to discuss with the patient, you need to discuss the patient, if I'm going to bring the patient to hospital now, or whether from emergency department or directly from home, what's the chances of this patient will develop COVID as a result of staying in hospital? The figure being quoted 0.4%, and that's based on American studies, but it clearly will be various between one country to another, between one region to another, and between one hospital to another. If we have 1,000 beds in Georgia and let's say we have 400 COVID patients, certainly the risk will be different from hospital have much less number of COVID patients. So although that's the coded figure in the guidelines, but clearly stated that will vary based on your local data. The second question will be raised, if the patient came to the hospital and developed COVID while they're having the major reconstruction, what's the chances of mortality? And the figure being quoted, the 30-day mortality will be 16%. So all these aspects need to be discussed with patients. The guidelines also talked a lot about how do we developing the pathway, testing the patient, limiting the number of the patient required to come to hospital. This is more applicable to elective surgery. When you plan surgery, so patient coming for pre-assessment or coming for multiple visits, we try to limit these visits to one visit if possible. And then we start talking well early about advanced care plan, whether this is include the discharge plan for the patient, how they're going to cope after surgery. And the other aspect of care plan that we are more aware of it now, what happened in terms of the if the patient developed cardiac arrest. So from day one, we will discuss with patient what they want us to do in case of cardiac arrest. Do they want us to have conversations? What's their thought? We share that decision with them. So every patient have very clear pathway and a clear long-term plan after the operation. So now we're talking about the revision we done during that time period. We did 16 revisions. We treated a lot of patients non-operatively, whether they've been given splints, braces for knees, crutches, or suppressive antibiotics. But the patient who failed the non-operative management, there were 16 of them, most of them female. And as you can imagine, in the revision surgery, the average age 70. And as you can imagine, those patients usually are medically very unwell with a lot of comorbidities. So they were ASA 3 or ASA 4. The indication was mostly for infection, 1 periprosthetic fracture, and 2 patients, they have periprosthetic fracture on background of chronically infected joint, and 1 dislocated total hip replacement that's required revision surgery. So I'm going to show some of the example of what type of patient we were operating on during that time period. This lady, she's 87. She presented to a local hospital with increasing pain and swelling, 3 days duration in her knee. They aspirated her knee and confirmed their organisms, and they started her on broad spectrum antibiotics. She also had peripheral vascular disease. She had bilateral lower leg ulcer. She had ischemic heart disease. So they treated her with broad spectrum intravenous antibiotics for 48 hours, but despite that, her CRP stayed around 300. So we transferred the patient to St. George's, and we did debridement and exchange of the insert and washout, and started to continue antibiotics, and then we changed the antibiotics based on sensitivity, and eventually she was discharged after 10 days, and she responded well for that particular procedure. So just to show the example that we are trying initially to treat the patient with antibiotic when possible, but clearly if they fail and there is no improvement, then we have to proceed with more the washout as in this scenario. This patient was on my waiting list. He's only 54. He had chronically discharging sinus from his left total knee replacement. However, suddenly during the pandemic, he presented 3 times to the emergency department with increasing pain and swelling despite the discharge from his knee. And then he started to have radiological changes in the distal femur. When we discussed it with the musculoskeletal radiologist, they thought this could reflect osteomyelitis, most likely, but also could be reflect underlying multiple myeloma. Especially he had another radiological changes in other parts of his body. So we arranged for him to be seen by the hematologist team. They did a bone marrow biopsy, but the results were equivocal, and we were not sure whether osteomyelitis or this is multiple myeloma. He had MRI scan, he had bone scan, but still we were not 100% sure. Although what's common is common, and we thought this is probably osteomyelitis, but we were very concerned because he had radiological changes in the skull and other parts of the body. So we did we had an MDT where we discussed him in details, and we decided to proceed with a stage 1 revision because of the increasing level of symptoms and because of the concern of multiple myeloma. In this scenario, we use all polytibia, which I use sometimes if we are not sure when we are coming back for the second stage, and we poorly cemented the femoral component to allow easy extraction during the second stage. And as you can see, there is a femoral and tibial cement rods inside the canals, and there's a lot of calcium sulfate. And the biopsy from the distal femur confirmed that was osteomyelitis, so he continued with intravenous antibiotics. He did very well, and he's back to work. And we're planning the second stage maybe toward the end of the year, and even maybe early next year. This patient, he's 86. He has a chronically infected total knee replacement, no sinus. We have organism for him. and he was on my waiting list to have a revision surgery, but he had increased level of symptoms, not responding to the tablets, antibiotics, and because of the increased level of symptoms, and we do have organism as well his medical morbidities, and he's 86, we did single stage revision for him. He stayed 3 weeks in hospital post-operative because he had some renal impairment afterwards, so that's required to be corrected, but eventually he responded well and he was discharged after that. This is another example, clear periprosthetic fracture. This operation done by no history of infection and done by my colleague. He revised the femoral components and reduced the fracture nicely, as you can see, with multiple cables, and left the acetabular component in place. And this is another example where there's no place for non-operative management, and you have to proceed with surgery for such patients. This lady, she has a chronic discharging sinus and total knee replacement. She has lymphedema in her lower legs. I did stage 1 revision for her toward the end of last year, and she was supposed to come for stage 2 toward January this year, just before the COVID started. Her operation cancelled for another medical reason, and then the pandemic started. So we were on hold for her to do the second stage. Then as the weeks start to pass, she started to have more and more symptoms in her knee, and she were unable to tolerate the cement spacer for a longer period of time. And as a result, we had to accelerate her admission to have stage 2 done much earlier than we would like to do because of the COVID and because of the pandemic of the COVID. But eventually, she did very well, and she went home. This is one of the most recent cases. This patient presented with a dislocated total hip replacement, and they tried attempt reduction in the emergency department. And as you know, when you use a Polish taper stem, if the head impinges, you have to be very careful, because that's one of the possible complications can happen. You pull out the whole stem from the cement mantle. So this required to be revised, and to both components being revised. So what's the early outcome? Obviously, it's too early to say what's the 1-year outcome, but so far what we noticed, we have extensive length of stay, more than what we usually keep our patient. Having said that, our revision for infection, they always stay between 7 to 10 days, because we don't like to send the patient with intravenous antibiotics unless we know exactly the sensitivity of the antibiotics. So we don't like to send them with the broad spectrum antibiotics. And the sensitivity, usually we have sensitivity by day 7, and therefore most of infection work on normal circumstances, they will stay around a week after surgery. However, in this scenario, many of these patients were unplanned admission, not being optimized, and hence require a longer length of stay. As you can imagine, major surgery, some of them have chronic anemia, 6 patients required the blood transfusion, 3 patients have renal impairment, which required medical attention to correct that. And we have 1 mortality, an elderly lady, ASA4. She had heart failure with pulmonary edema, and she went to have a proximal femur replacement. Unfortunately, she didn't do very well post-operatively and died as complication of pulmonary edema. So what are the challenges of these patients when we look at this small cohort? The number 1, lack of optimization of patients. So initially, when I talked about the complex arthroplasty unit, the strong part of this unit, we have the access to multidisciplinary teams. We have access to high-risk anesthetic clinic, patient being assessed there. If they're anemic, they go straight away to anemia clinic, where they're given assessment for their anemia. They're given intravenous iron, or they're given blood transfusion, whatever needs to be done. So all that optimization we lack on emergency admission. And that's always the case, just like when you have a fracture neck of femur with hemoglobin 80, but you have to do the operation, and you have to optimize it as much as you can prior to surgery. The second challenge, these patients in normal circumstances, they are very medically challenging patient. They have a complex past medical history. They are a high risk of morbidity and mortality afterwards. And therefore, if any of them get an COVID-19 infection, they will have a higher risk of mortality. And of course, that was very concerning to us and to our patient. How do we minimize that risk, and how do we optimize the best pathway for these patients that we can perform the urgent operation in the safest way we can offer to them? The other challenges, other than the patient, is our theatre capacity. In the model I showed, when we're using the theater as one room, the efficiency of the theater has dropped a lot, and we lost a lot of theater availability because they canceled all our theater sessions for elective surgery, and the staff who meant to manpower this elective surgery have been distributed to other medical specialties. So now we have a less number of operating theater, and we have a lower efficiency. So we are doing one case per session. Instead of doing 4 operations per day, we are doing 2 operations per day. And then obviously there are other smaller issues, but still effective flow, like kids availability. The companies, for example, not available to provide any clinical support during that time for the staff because of the limitation of the visit to the hospital. So all these add together extra challenges when you're planning to do any of these operations. After the operation, the challenges we face in normal circumstances, all these patients will require a high dependency unit bed. They have to go to the critical care unit for extra medical care, especially the first night at least, because they are all ASA4, they have arterial lines, they have a lot of medical problems that need a strong medical attention. During the pandemic, one of the main shortage we have is the lack of critical bed, because all these beds being prioritized for the COVID-19 patient, which they need as much ventilator, as much critical care beds available. Hence, providing beds for these patients was very challenging. And the other challenge, even if we found a bed empty for one of our revision work, we don't want to have this bed in a big unit where are a lot of COVID confirmed patients being nursing next to them. So we want them to have a critical care bed, which is not available or very difficult to be available, and want this bed to be isolated either in a side room or in an isolated area of the critical care unit to make sure there will be no cross-contamination, which was a very difficult challenge. And as I mentioned earlier, all these patients did have a prolonged admission. And prolonged admission for many reasons. Part of it, lack of optimization, but the other part is also lack of physiotherapy services and social services in the community, because now all the physical services has stopped, either to limit the face-to-face consultation, face-to-face support, where in normal circumstances we are happy to send patients at much earlier date. We are aware there will be physiotherapists in the community continue the care, there will be social services support for them, and if they require intravenous antibiotics, there will be intravenous district nurse deliver that antibiotics in the community. These services become very limited during the pandemic for obvious reasons, for infection. Hence, we have to keep the patient longer period of time until we are more comfortable that the patient are able to manage to good degree on their own in their normal home circumstances. The other challenges we have post-discharge is the follow-up. All these high-risk patients, we like to monitor them closely. Usually they have a 2 weeks follow-up, ensure the wound has healed, there's no major issues, the patient progressing as planned, but we wanted to limit their visit at the same time to the hospital, and that's where we start to use a lot of the virtual follow-up clinics. Other effects, the increased waiting time for elective surgery. There are many patients waiting elective surgery, whether primary or revision surgery. All these surgery are being put on hold. So instead of waiting 2 months, now they're waiting 2 months plus all the waiting time during the pandemic where the elective surgery have been stopped. And if anything, the waiting time will be more because during the pandemic, we were still running clinics, especially for the follow-up patients, and we were still adding some patients to the waiting list, so more patients adding to the waiting list, and at the same time, we were not operating any elective surgery. And now we have some data coming clear, like if you look at the American data, nearly 1,400 revisions being cancelled per week, and this is not unique to the United States because a survey on nearly 100 surgeons from 30 different countries, 70% of the surgeons have stopped elective orthopedic surgery, which indicate that it's worldwide problems increasing the waiting time and the cancellation of the elective surgery. Other effect is the training and the education. Those residents or registrars during their training time and their placement to learn more about arthroplasty during this 6 months or during 1 year, they have much limited exposure. And as much as you try to do virtual training and do online training, there is no replacement for the actual hands-on exposure. For us, for example, we have a post-CCT Australian fellow, so that will limit how much exposure these fellows they have, although he limited to a lot of revision during that time, but for 2 months we are not doing any primary joint replacements. So when we look back with what lesson we learned and what we will use again if we have a second wave or if you have any other national emergency that we need to modify our clinical practice. There are things we cannot change. We cannot change these cohort of patients, the cohort of patients where there are ASA4 with a lot of medical problems and there are chronic discharging sinus, not well, heart failure, lymphedema. We cannot change any of these factors. Also, we cannot change the way they present to us, whether CRP 300, they are unwell, or complex periprosthetic fracture that requires surgery. There are things we don't have any influence to change. And also, it's very difficult to predict how many patients they're going to present to us during a certain period of time. And that's always been the case in the trauma surgery or the urgent emergency admission. We can have 1 week where relatively quiet, you have 1 or 2 major admissions, or you can have 5 or 6 patients in 1 week that require revision surgery. So it's very difficult to predict these factors. But certainly there are things we can utilize more and we can benefit from the experience of this time, like utilizing the non-operative management, using the suppressive antibiotics for the infected joint when the patient doesn't show any signs of sepsis. And also having that more emphasis on the shared decision and the consenting process, not only for the actual operation, but the other risks like the COVID, the pandemic risk, how the patient wants us to proceed during the pandemic. And that shared decision is very important during this time. The other things we find it very useful is to identify the patient's pathway, whether it's red and green, red, amber, green, whatever coding system, but there should be a pathway for each type of patient, depends on their risk of developing an infection, their medical morbidities, as well as the possibility of themselves of having an infection. So patients who are now, for example, isolated at home for 2 weeks and then being tested, we go in our hospital to complete green elective pathway, where the chances of this patient having a COVID is very minimum. While patients who've been admitted from emergency department, they completely go to different pathway and the different section of the X-ray department, different ward, everything, different theater sessions, completely different pathway. And testing the patient and isolate the patient early, we find a very effective way to control the post-contamination. Operating room availability is another matter. We look at it and we say, even if you cancel the elective surgery, but in these circumstances, the efficiency of the normal work for normal trauma operating room will be less than the expected activity, and hence keeping extra session will be always useful, even if you're not going to utilize it for elective surgery, but will suck a lot of the extra trauma burden you're getting during these weeks. And having HDU bed is very important to have isolated critical care beds for post-operative patients who are non-COVID patients, but clearly require extra medical care in isolation from the COVID patients. One of the things we came across, there was a lot of guidelines and protocol from hospitals, from national bodies, from the BOA, from the British Hip Society, and sometimes it's just very difficult to keep up with the updated protocols and guidelines. And sometimes locally you have guidelines on Monday, by Thursday, something has changed. And what we found it as a unit ourselves very useful to have every day. We have like an evening meeting using Microsoft Teams, where we brief ourselves on the most up-to-date. So the briefing will be how many patients we have with COVID in the hospital, how many orthopedic patients, number of patients waiting surgery, what their capacity we have over the coming 2-3 days, and if there's any update in the guidelines. And you can have just 20-minute briefing every day, but to keep everyone on the same page, and everyone will be up to date with what's the most updated guidelines and where we are standing as a unit and what help we can offer the hospital. The other things we definitely would take over with us from that experience is using the virtual physiotherapy and using the virtual follow-up clinic. And now it's something we have built up in our future clinic, that the patient, once you arrange follow-up, you decide you want a virtual follow-up or you want face-to-face follow-up. Because there are a lot of patients, they don't need to come back physically to the hospital, And as a long term, this pandemic gave us something in the positive way to utilize more of virtual clinics in our service and in our practice. And that's Sean coming to the end of my presentation.
Thank you very much for that. It really was a very comprehensive presentation. I've been noting down some questions as we went through, but you were ticking them off as we went. So really appreciate you taking the time to put that together. Now I have a few questions of my own that I would like to ask following that, and there's been a few questions typed in already. But just to draw everyone's attention to the right-hand side of your screen, you have a small bar which you can open up, and there's a question section. So please feel free to type any and all questions in there, and we'll work our way through some of those. So the first question I would like to ask is regards the elective capacity. So you mentioned that at the moment, due to reduced number of staff and pressures on operating time, that you're only doing around 1 to 2 procedures per day as opposed to 4 or 5. Is that still the capacity that you're running at? And when do you expect to return to full capacity, or is there any measure in place for gradually increasing the numbers?
No, that was the capacity during the actual pandemic. So that's mainly March, April time. In terms of the elective orthopedic center, we started resuming our elective activity back in July. And we started initially with ASA1. So all patients have risk stratification based on what risk these patients. So we started with the ASA1 patient. To some extent, we're not looking how long the patient been waiting, but we're looking how safe is the patient to have operation at this period of time. And we tell the patient, this is the situation, this is what we are taking the precaution. And most patients elected to go ahead with the operation. We started operating in July, and now we build up to ASA 2 and 3. And we also color-coded the patient depends on the risk. So we start to operate on more high-risk patients. But what has changed, based on the guidelines from the Royal College, we contacting the patient, like I contact all my patients at least 10 days before the date of the surgery to discuss again the risk of COVID-19. I virtually consent them for that risk, and we post to them actual written consent for COVID-19, which the patient have to sign in addition to the normal consent process. The patient who are at the elective orthopedic center or at St. George's will follow the green pathway now. They have to isolate for 2 weeks' time. They have to have a negative swab prior they coming to hospital. And in this way, we are very confident that the chances of getting an infection will be very minimum.
Okay, that's great. Thank you. You've obviously explained to us a bit about what St. George's and your trust down there in London, what they've been doing to manage this. Do you feel that we should have had more of a national protocol, or do you feel that it really needed to be done on a local basis, so trust by trust or hospital by hospital? What would be your opinion on that?
I think it will be very useful to share the experience worldwide and as well as nationally, because it's a very good idea to learn from other people's expertise and learn from other people's experience and not to repeat the same mistakes. If we're not going to share together, I think everyone will repeat exactly the same mistake and learn from their own mistakes. So definitely sharing, and I'm sure at some stage there will be reflection on all the practice being done and with some national recommendation as what's the best way to move forward in the future.
Yeah, for sure, for sure. You mentioned at the start of the presentation that things like your trauma meeting now are being done digitally. Do you think that you will maintain any of those digital measures once we're past this pandemic era, if you will? Do you think there's any of those measures which will stay?
We are actually maintaining certain things. So definitely the trauma meeting virtually is something we like to maintain. Best example, when you have an operating theater day and you're on operating inside theater, we always have this dilemma. You want to do the team brief early, you want to show you present there so the team keep moving, but you don't want to miss the trauma meeting as well. But now the surgeon easily can do team brief, and while this being sent to the patient, he can join the trauma meeting while he's in theater office. So we find certain aspects definitely very useful. You don't have to be physically in the same room to join the trauma meeting. So that's one thing we take with us. The virtual follow-up is definitely something we take with us as well in terms of the outpatient clinics.
Yeah, for sure. We have a couple of questions which I'm just reading from the side panel here. So the first one was just asking if you're shielding post-surgery and for how long?
Initially, they were recommended for the patient to shield post-surgery because the concern, if this patient has actually developed an infection and he incubating while they are discharging, they may spread the infection to a household. Initially, we're 2 weeks, but later on, that's been shortened period, much less than that. In practice, it's very difficult to know how many of these patients actually stick to these guidelines and they are shielding at home.
Of course, of course. Have you separated your staff into red and green areas, and are you testing the green staff for COVID currently?
All the staff being tested for COVID, yes, and it's optional, it's not obligatory, but all the staff been offered to have a test for antibodies. We did not separate initially the staff in the initial phase, and there was always this dilemma, even with the surgical. Do we separate the surgeon as well? I mean, we have a red surgeon and a green surgeon. The red surgeon will only operate on COVID patient, and green surgeon only on non-COVID patient. But there was no general consensus as how to arrange for that, plus the rota and the way it works was not feasible. However, now as things more settled, the ward where the nursing staff look after the COVID patient, they try not to mix them, if possible, with other wards, so to stay with that. But as a formal separation, no, that was not taken.
Did you find that the management in the hospital were apprehensive in permitting the treatment of infected patients and what to do with them post-surgery?
I think yes. I think from our St. George's experience, they were a huge supporter to provide our service. We also understand the limitation we had and what facilities we have during that difficult time and how much the things are available and things are not available. And but as far as our unit, we are lucky that we have a really good support from our managers in provide this service for these patients. The manager understands we are a tertiary referring center for the arthroplasty, so we have to receive these patients and deal with the management of these patients.
Okay, thank you. What was your feeling in regard to the use of laminar flow theatres during the pandemic? My understanding is that there was very little evidence as to whether these would offer any benefit or risk. So what was your stance on that?
So initially, absolutely right. There was a lot of concern about using the laminar flow. Should we switch it off? And the same things with the helmet, the spacesuit, in arthroplasty. There's a lot of concern. Should we use it or not? We started using it quite early. We started quite because the evidence were very weak to suggest that not using it, and we thought the benefit of using it will outweigh not using it. So we are using the laminar flow quite early from surgery.
Yeah. Okay. Has this pandemic affected your decision-making process with your complex revision surgery, or I guess with any surgery, to try and reduce exposure time in theatre? Is there anything that you would be doing differently now moving forward?
In terms of surgical plan, not. Like we did not go straight for mega prosthesis just because that would be a shorter, quicker operation in terms of the COVID itself. But in terms of timing of surgery, indeed, because many patients would like to do the revision for infection much earlier than possible, but we are treating them at that stage with suppressive antibiotics, try to prolong as much as possible before we go to this stage of revision. Because to reduce the risk of infection. So that aspect has changed. But in terms of the surgical planning itself, did not change much for us for revision surgery.
Yeah. You mentioned that a lot of your staff were taking from theatres to put into other medical specialities within the trust. Will those staff be put back into orthopaedic theatres again? Were they specific ortho staff, or will you be retraining new staff moving forward? And how would you?
That was one of the problems we had initially, because a lot of our orthopedic scrub nurses, they have a critical care background. They pull to support the critical care unit, and then we all start operating with non-orthopedic nurses inside the operating theatre, which is really difficult for the nurse who scrub, difficult for the surgeon, and is not a practical or efficient way of doing it. And even when things start to settle down, it took some time until we start to have our nurses back to theatre So that's one of the things ideal world, we should avoid doing that. But in that particular moment, that was the decision because of the need for their skills in the critical care.
Yeah. And the final question that I'm going to ask myself before we wrap up, we're getting close to an hour here, is do you see firsthand any sort of psychological effect that this pandemic has had on your department or on your staff, and what measures do you think need to be in place to make them comfortable returning to normal, whatever we're now calling normal?
It has positive things and negative things. The positive things, I think, it was the unity between the department, between the hospital, because everyone has stand up to help each other. I mean, we as an orthopedic team, we went to help the medical team in the critical care unit, and that support to them just show the unity between the different teams. And the same within the actual orthopedics department, there was a lot of support to each other. So that was really positive experience. The negative part is the changes which happen in a very short period of time. The changes how we run our clinics. Definitely there was a lot of pressure on certain member of staff who do even the admin work, when you have to change the whole templates of doing the way you run your clinic, run of data. There's a lot of pressure on the staff, and that's extra support was really needed during these times. And the managers and the department and the hospital as well try to provide as much support as possible to everyone, but is understandably it was a difficult time to rechange the way we've been practicing for years.
For sure, for sure. Well, I mean, I think we're all on the same page in hoping that we don't see too much in the way of a second wave, and that hopefully we have learned enough from this to be able to put the correct measures in place and minimize the impact moving forward. But I certainly agree that I think the shared practice, everyone being in discussions with one another, even what we've listened to with yourself today, getting a chance to see how one hospital has coped and survived with the situation is very, very useful. So I'm just going to quickly ask if there's any additional questions from anyone in the audience they would like to ask before we wrap up for this afternoon. And whilst we're giving everyone a chance to type that out, if there are any, I will just take this opportunity once again to thank you, Mr. Alazawi, for your time. I really do appreciate you putting together that presentation for us and sharing your experience with this COVID-19. I know it's been a very interesting time, to say the least.
Thank you very much, Sean. Thank you for the invite. I hope it was useful for the audience as well.
I don't think we've got any new questions coming through right now, so we shall wrap it up for this afternoon. But yes, once again, just many thanks, and obviously take care of yourself as we're moving forward over the next few months, and I look forward to catching up with you soon.
Thanks, Sean. Take care.
Many thanks for your time, everybody. Bye now.